Bariatric surgery. It is also known as metabolic surgery or weight loss surgery. It is a term for surgical procedures used to manage obesity and obesity-related complications such as type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, osteoarthritis, and many more complications. It helps in weight loss by reduction of stomach size, malabsorption, hormonal, or a combination of these mechanisms. Hormonal factors in obesity and its application in bariatric surgery. Ghrelin. It is produced from P/D1 cells, which is located at the fundus of the stomach. It is known as the hunger hormone and it is one of the orexigenic hormones. In most of the bariatric surgeries, the fundus of the stomach is removed and the patient will not feel hunger often, thereby reducing the calorie intake. Incretin. GLP-1 is an incretin produced in lower small intestine. It is important and basically a good hormone to control blood sugars. Anti-incretin hormones are produced in the duodenum, especially D1. Some bariatric surgeries exploit this feature of our body, and the food directly enters jejunum, thereby bypassing the duodenum, stops anti-incretin to be produced. Indications for bariatric surgery. BMI greater than or equal to 40 kg per meter square. BMI greater than or equal to 35 kg per meter square with obesity complications. Let's recap the common complications of obesity. Obesity causes type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, osteoarthritis, gastroesophageal reflux disease. These are just a few. Obesity causes much more problems. Let's get back to indications. BMI greater than or equal to 30 kg per meter square with onset of type 2 diabetes in the past 10 years. BMI greater than or equal to 37.5 kg per meter square in Asian population. The reason why bariatric surgery is indicated at a lower BMI in Asian population is because they tend to be vulnerable to complication of obesity, even in lower BMI. BMI greater than or equal to 32.5 kg per meter square in Asian population with obesity complications. Contraindications to bariatric surgery. Mentally incompetent to understand the procedure. Inability or unwillingness to change lifestyle postoperatively. Drug, alcohol, or other addiction, including smoking. Active problem of bulimia or other eating disorder. Psychological instability, example, schizophrenia, severe depression. Unsupportive home environment. American Society of Anesthesiologists Class 4. Preoperative considerations. Liver shrinkage diet. It must be followed for at least 2 weeks before surgery. The patient must take high protein and low carbohydrates diet. During bariatric surgery, the liver must be moved. In fatty liver, the operation becomes difficult as it is tedious to move the fat liver. Even just 2 weeks of liver shrinkage diet greatly reduces the fat in the liver and the operation becomes easier. Smoking cessation for at least 6 weeks prior surgery. Smoking impairs collagen formation and post-operatively there will be poor wound healing and increased complications. Oxygen therapy and obstructive sleep apnea. Obstructive sleep apnea increases the risk of post-operative anastomotic leak. Thereby oxygen therapy is beneficial for these patients. Dietary and lifestyle changes. Proper counseling. Obesity surgery mortality risk score. Arterial hypertension is given a score of 1. Age more than 45 is given a score of 1. Male gender is given a score of 1. BMI greater than or equal to 50 kg per meter square is given a score of 1. If there is any risk factors for pulmonary hypertension, a score of 1 is assigned. Higher the score, higher the mortality. A score of 0 to 1 has a low risk mortality of 0.31%. A score of 2 to 3 has an intermediate risk mortality of 1.9%. A score of 4 to 5 has a high risk mortality of 7.56%. Types of bariatric surgery. Purely restrictive. In restrictive surgeries we remove a part of stomach, reducing its size, and the patient experiences early satiety. Some restrictive surgeries are sleeve gastrectomy, laparoscopic gastric adjustable banding, malabsorptive. In malabsorptive surgeries, the small intestine is bypassed and the food the patient eats is absorbed only partially. Purely malabsorptive surgeries are rarely done nowadays, and I have added it just for completion's sake. These are jejuno-ileal bypass, jejuno-colonic bypass, restrictive more than malabsorptive surgeries, Roux-en-Y gastric bypass, mini gastric bypass, malabsorptive more than restrictive surgeries, biliopancreatic division, BPD with duodenal switch. Only the highlighted surgeries are done nowadays. Let's look at them one by one. Laparoscopic sleeve gastrectomy. Procedure. Fatty attachment to the outside wall of stomach is carefully clipped. Sleeve gastrectomy stapler is used to staple and cut the stomach. The surgeon carefully makes the stomach into a banana-shaped tube by placing the staples one section at a time. The extra stomach is then removed through the side port. Complications. It results in nutritional deficiency such as iron deficiency, anemia, vitamin B12 and calcium deficiency due to the simple fact that iron, vitamin B12 and calcium need hydrochloric acid for their absorption. Bleeding from stapler line. Leak from angle of his. It is known as the Achilles heel of the sleeve as it takes months to heal owing to the high pressure generated by the intact pylorus. Laparoscopic adjustable gastric banding. It is a reversible bariatric surgery. Once desired weight is achieved, the gastric band can be removed. Procedure. Adjustable band is placed 6 cm from GE junction. The porta balloon, as highlighted here, is placed near umbilicus. The surgeon then takes a syringe filled with normal saline and the balloon is insufflated with normal saline. As the balloon is insufflated, it compresses the stomach and a small virtual stomach pouch is created. The size of virtual stomach can be adjusted according to patient's wishes through the access port. This leads to early satiety and weight loss. Roux-en-Y gastric bypass, RYGB. Procedure. In Roux-en-Y gastric bypass, a small, 15 to 30 ml thumb-sized pouch is created. This restricts the amount of food that can be ate. The stomach may be simply partitioned by surgical staplers. Or the stomach may be divided into 2 separate parts also using surgical staplers. The small intestine is divided approximately 45 centimeters below the stomach outlet. The remaining part of the small intestine that is roux limb and its continuity is anastomosed with the stomach pouch that is gastrojejunostomy. The small intestine that is attached to the stomach outlet is anastomosed with the roux limb that is jejunostomy. This completes the Y configuration. Length of the roux limb. For peptic ulcer, the length of roux limb is 50 centimeters. For bariatric surgery, it is 100 centimeters, and for super obese patient, it is 150 centimeters. Mini gastric bypass surgery. Procedure. This is a variation of Roux-en-Y gastric bypass surgery. The surgery is almost the same as the Roux-en-Y gastric bypass, except that, instead of dividing the small intestine is directly anastomosed with stomach, that is gastrojejunostomy. Biliopancreatic division, BPD, and biliopancreatic division with duodenal switch, BPD-DS. These surgeries result in maximum weight loss due to maximum malabsorption with these procedures. But due to high mortality associated with these procedures are rarely done nowadays. These procedures are associated with highest nutritional deficiencies post-operatively.